The next panel discussion will be to discuss is active surveillance after focal therapy the same as de novo active surveillance, and the intensity and interval of surveillance after focal therapy. So we have on the schedule Dr. Labachi, but I don't think he's here at the time. Yeah. So we'll have Dr. Tan go over to the next lecture. Yes.
Well, thank you for the invitation to talk about imaging only after focal therapy. So I've been assigned this topic, which I'm going to try my best to justify, even though there's not much in the literature pertaining to this. I have no disclosure. So first, I wanted to elaborate on the surveillance protocol that we use at NYU. Essentially, we check a PSA at month 3 and month 6, followed by a PSA every 6 months. After cryoablation, we get an MP-MRI some point between 6 to 12 months, and subsequently at year 2, year 3.5, and at the 5th year mark. Previously, we used to do surveillance biopsy, meaning scheduled biopsy at month 6, 2 years, and 5 years. We also do 4-course biopsies if there is a suspicion for recurrent prostate cancer. But since my partner, Jim Weissau, published his series back in 2021, when we retrospectively reviewed, when we looked at our prospective database, looking at patients from 2017 to 2019, essentially we had 70 men underwent a 6-month protocol biopsy. And, you know, in the ablation zone itself, 94% of men did not have an infill recurrence. If we're looking at grade group 2 or higher disease, so we define as clinically significant prostate cancer, we had a 1%, one patient that actually had it in the ablation zone only. When including the 12-core templated biopsy, for grade group 2 disease, it essentially stayed the same, but for grade 1 patients, we found a few more cases of that. So because of that, we changed our protocol and we removed the 6-month scheduled biopsy because of that. We were still doing 4-course biopsy if there was any suspicion pertaining to prostate cancer recurrence. So the big question is, how good is MRI at determining recurrence? Well, I guess, you know, it all comes down to, you know, this fancy table over here. Essentially, because our prevalence of disease recurrence was so low, regardless of how good the test is, our negative predictive value was, you know, it's going to be pretty high because the true negative value is actually so low in a prevalence like this. So essentially what happened is that, you know, regardless of what test we were using, we're probably not going to find cancer because cancer just didn't exist in that patient when you're getting such good outcomes. However, this is not the end of the talk. You know, we still got to discuss a couple of things on how MRI would actually affect things. And I think a lot of it actually comes down to your practice itself. It comes down to how high your recurrence rate. So that's going to be one of the factors that determine that. I wanted to put up 2 cases as an example. So this patient, his pre-op PSA was 9, and he had a Pirates 3 lesion. Ultimately underwent a transperineal fusion-guided biopsy, was found to have grade group 2 disease on the MRI lesion. Subsequently underwent a partial gland cryoablation and a TURP in the same setting. His post-cryo PSA was 4.3 at 3 months. And on 6 months follow-up MRI, essentially it showed, you know, an ablation zone in the, this is the preoperative MRI. This is the post-operative MRI. Essentially it shows a ablation zone in where the tumor used to be. He also underwent a TURP. And that's why the median lobe is no longer present. But essentially, in someone like this, you know, we do not expect to find cancer there. There is no enhancement on DCE. This is a clean ablation. It looks good. The radiologist read it as, you know, expected ablation zone. And naturally, at 6 months, when we biopsied him, no evidence of disease. This, on the other hand, is a different case. This is a 70-year-old man with a PSA of 5.56. Came in with an outside hospital biopsy. Found a grade group 3 disease. You can see on the right side, right posterior essentially lateral. he was taken for a cryoablation. We did a quadrant ablation, essentially cheating a little bit past the midline. You can see the ablation defect in that area. So a 9-month MRI, essentially he came in with a little bit of contrast enhancement. The radiologist called it 4 millimeters of contrast enhancement. You could see his PSA trend responded nicely. He went down from 5.56 to 2. And because we changed our surveillance protocol, so he actually did not undergo a biopsy at 6 months. His PSA, interestingly, continued to stay relatively stable at 2.3, but on the 24th month, we got an MRI once more, and it showed kind of a stable area of ablation where there was a previously 3 centimeter ablation defect on the right posterior lateral apex. And at 24 months, it was slightly smaller, but there was still that 4 millimeter, 10 by 4 millimeter focus of enhancement on a DCE. So on the 24-month biopsy, he was found to have a recurrence in that area, grade group 3 recurrence. He had a PSMA PET then, which showed no evidence of metastatic disease, and we were able to salvage him with SBRT. So it shows the difference in terms of the MRI, picking up something on the second case here. But I believe that in general, when you look at the prevalence of abnormal MRIs, this is our data at NYU where we looked at 300 patients who underwent a 6-month MRI post-cryoablation. 87% of them were read as no concern at all. So perhaps this patient could have avoided a biopsy, at least within the first year. That 12.7% who had an abnormal MRI, though, that's the area of interest on how we should tune up our suspicion in terms of picking something up. So this is a scoring system proposed by the UCL group. I actually reviewed their paper for European Urology Oncology a couple of months ago, and it looks like it's in press. Essentially, what they're proposing is they're trying to define this as a PIFAP score, which is a 3-point score that essentially tells you the suspicion on how likely you're going to find prostate cancer in the ablation zone. So essentially, if you have no contrast enhancement, they call that a PIFAP-1, and they're proposing that you could perhaps just continue monitoring without a biopsy. Whereas on the other hand, if you look at the other extreme, PIFAP-3, they recommend a biopsy. And they define that as DCE with 3 millimeter or larger, on your scan. And if it's enhancement that is under 3 millimeter, they define that as PIFAP-2, and they actually left it up to the clinician. There isn't much data pertaining to this yet, but I think the UCL group is trying to create a registry so that they can better understand this. Essentially, when we looked at it, patient number 2, which I presented earlier, would fall into the PIFAP-3 category. So if we were to use this score, the patient should have undergone a biopsy. So I think at the end of the day, to determine if all you need is an imaging, like what Mark Emberton would do at UCL, essentially you got to know your oncological outcome. If your oncological outcome is sound and you trust your radiologist, and you don't see anything abnormal on MRI, perhaps imaging itself would be sufficient to follow these patients without a biopsy. I do think that we need to be very cognizant that the field of focal therapy is relatively in its infancy. So to begin with, perhaps it makes sense to biopsy all your patients until you know your true oncological outcome, and your team get a sense of how how low the disease recurrence is or how high it is, to actually taper your surveillance protocol to determine if this same protocol that we use will work for you. The way I think about it, I have a low threshold to perform a biopsy even at 6 months to 12 months if there is something abnormal on the MRI. But if the MRI looks good, in our practice at least, we've been avoiding biopsies at within the first year, but we still do a scheduled biopsy at 2 years. There's some thoughts pertaining to the fact that perhaps some of these lesions that we're picking up early on could be granulation tissue, or it could perhaps have been low volume of cancer that we're just not able to target back right after the treatment. But perhaps at 2 years, that gives it the opportunity for it to grow, and it'll be it's a bigger target that you're trying to biopsy, and perhaps then you're diagnosing this patient. So we're actually going back, looking at our series in patients who had biopsied at 2 years and 5 years to determine if the MRI at 6 months could have predicted whether they would recur at 2 to 5 years. And we are hopefully sending it from publication soon. Thank you.
So I have a question for you, and that is, do we know exactly the healing time by the different energy technology? And can you determine that by MR, do you think?
That's an excellent question. So I do think that the healing time for various technology differs actually, specifically for cryoablation. I was talking to my pathologist about it, and we were trying to determine if we should actually delay the MRI at 6 months and perhaps do it at a year, as long as there is no concern for recurrence, meaning the PSA is pretty low and there's no nodule, no new nodule on DRE. The pathologist seems to think that by a year, the area of ablation would be stable, meaning you're gonna not get any more granulation tissue. We did go back and look at that 13% of patients who had an abnormal MRI, and 15 of them actually had contrast enhancement on the ablation zone. But when you look at the 2-year MRI subsequently, only 6 of these patients actually still have enhancement, meaning 9 of them actually disappeared. So how to tease out if, you know, when the treated area is going to stabilize, we actually don't know yet. But from a pathological standpoint, I think most pathologists think it's some point between 6 months or 12 months before it stabilizes. So hopefully in the near future, we'll have a lot more information pertaining to that as to tell us whether we should be biopsying these patients, you know, before the 1-year mark.
Okay. Any additional questions? Okay. Our next speaker will be Dr. Ukumura, discussing the use for targeted biopsy only for surveillance and follow-up after focal therapy.
Thank you.
Thank you.
So my talks are intended to more focus on the targeted biopsy in the active surveillance or monitoring after focal therapy. So first of all, I would like to think about the natural history of prostate cancer once we apply the focal therapy. So index cancer is initiated, but we may have insignificance which may be invisible in MRI, as well as systematic biopsy may miss to sample it. At that point, we may focal therapy done. Such index cancer can be controlled very well, but potential missampled insignificant cancer can grow, or a new lesion can be detectable. So not only the MRI, we also needed to focus on the change of PSA. Our institutions will protocol MRI and PSA follow-up every 3 months PSA, every 6 months MRI. Likely when the record clinical significance in the prostate, PSA likely elevated, and also MRI visible lesion can be appeared. This is the timing for the surveillance biopsy. But what kind of biopsy need to be? That's my focus on this presentation. So we learn from the active surveillance protocol, risk-based follow-up, which was published by Roberson, the previous study. The importance is first progression patient may benefit from the frequent biopsy. In contrast, slow progression patient may subjected to unnecessary also the biopsy-related adverse events. Therefore, they do not have a standard uniform protocol of active surveillance yet. So active surveillance protocol should be individual basis, so we can learn from this. So difference between de novo active surveillance and our active monitoring after focal therapy is the objects of the treatment is totally different. Active surveillance can be insignificant cancer, focal therapy for clinical significant cancer, and PSA can be stay abnormal in de novo active surveillance, but ours are down to normal, likely. In contrast, MRI can be invisible in active surveillance, and in case it's going to greater the visible. In contrast, after focal therapy, MRI visible region likely disappear. If recalled, it can likely be this appearance. So risk-based follow-up can be learned from the de novo active surveillance protocol. Then I would like to propose, especially biopsy methods could be determined based on risk of pre and post-focal therapy parameters, including biopsy-based, MRI-based, and PSA-based. We know the shortcoming of systematic biopsy. Systematic biopsy have a shortcoming about missampling, undergrading, sampling errors, understaging, and evaluation of cancer volume. Then we have a long time introduced the organ tracking based biopsy methods. This technology allows importance of revisiting technique for more reliably monitor that prostate cancer characteristics, which means temporary and spatially multifocal. So first, important targeted biopsy is revisiting the same spot. Very left side view, systematic biopsy pickup, insignificance positive biopsy in 3 spots. 1 year later, we may revisit the same spot, and multiple biopsy were now positive in 5 spots, increased from 3 spots of insignificant positive biopsy can be revisited in results 5 positive biopsy. This kind of precise targeting revisited the previous positive biopsy is important targeted biopsy technique. Another targeted field biopsy can be done using these important technologies. Let's say in far left side, every single systematic biopsy were negative. But far right side view, you can see I can revisit unsampled field of the prostate, which has never sampled by first look biopsy. So this means 12 core biopsy plus 12 core biopsy can be 24. But if without using this technology, 12 system biopsy plus 12 systematic can be now less than 24. So in surveillance biopsy, targeted unsampled field biopsy makes sense. So second look targeted field biopsy plus negative first look systematic biopsy means 24 saturation biopsy set. So if without this technology, a first look biopsy plus second look biopsy may less than 24. Some of them can be sampled from the same area if the biopsy position have not been recorded. So let's think about the MRI results and the PSA results. So our case, our experience, such a visible MRI region can be very clearly disappeared. This case also, contrast enhancement is very important when do focal therapy. Our focal therapist should do not biparametric. We should do, before focal therapy, we must do, including enhancement, multiparametric MRI, because recurrence or new lesion likely important in doing the contrast enhanced MRI. And if it is successful, PS-like, normalized like this, but in our experience, when MRI visible lesion appeared, PSA likely again return to abnormal levels above 4. Embert and Moore's group importantly pointed out PSA change after the focal therapy, PSA reduction between over 50% is suggested the well control of index cancer. So I propose also reduction rate over 50% is important, as well as over 4 nanogram milliliter of the standard cutoff is as important as well. We recently published the MRI change, time course change in multiparametric MRI following the cryotherapy. So typically, over 85% of my patients have a very nice invisible in MRI, as well as PSA is normalized and continuously nadir like this case. But the recurrence case very likely have return back PSA elevated time by time and going to above 4. And at that time, likely we can identify the MRI visible recurrent part, especially the enhancement MRI is most important. So the last also pointed out the Moore's group just 2 months ago proposed the PI-5 scores. They also emphasized PI-5-2. MRI suggested something, and PSA kinetics, our abnormality of a PSA is very important, and the MRI can be used for surveillance. They also introduced the precise score as well, but these needed to be evaluated in the multi-institution. I also importance of another targeted biopsy at this moment. That means named by periregional targeted biopsy, because MRI can be underestimated. So periregional targeted biopsy is very important when we repeat the focal therapy in this area, how much safety margin need to be created according to the positivity of periregional targeted biopsy. So this is the final. I would like to do the risk-based follow-up, especially focused on the combination of targeted biopsy. One is MRI fusion targeted biopsy regularly, and periregional targeted biopsy. And if we need the out-of-field biopsy, targeted field biopsy, which has never sampled even the initial diagnostic biopsy. Thank you for your attention.
Do we have any questions? Thank you.
Thank you.
Our next speaker will be Dr. Peter Pinto for discussing targeted plus the 12-core random biopsy.
I want to thank everybody for staying at this time. Yesterday, I kept you from a drink at the reception, and now I stand between you and seeing your families and your loved ones. Thank you to the organizing committee for putting me last. I was on that committee. Oh, gee whiz. I accepted myself going last because I helped pick some of the speakers for this session. That's okay. All right. So I kind of thought this was a debate. And I always lose to Osamu because he always wins, so I defer to him. But I will say that I think there's a compelling reason to do both targeted and also 12-core. For full disclosure, so as a federal employee of the U.S. government, through a CRADA, we did work in the development of the urinary biopsy platform over many, many years, and I'm on the committee for the AUA guidelines, just having put out the one for prostate cancer screening, and no other interests are held in relation to this. Well, the blind biopsy, so that's the 12-core part. We all want to get to a position where we can dump the 12-core biopsy, and it makes sense, because if that's the tumor in that piñata, what the hell are we doing? I mean, that's what we've been doing for decades, right? And and you keep punching and biopsy and punching and biopsy and keep focusing on. I can tell you right now, he never gets that tumor, right? It just doesn't happen. So as a result, we have to realize that that's just something that's archaic, and we move on. Under samples, it gets less than a percent of the prostate, and it always drove me crazy when I was in training that if a prostate was 25 grams. You do 12-core biopsies. And if it was a 200-gram prostate, you did a 12-core biopsy. Maybe you throw a couple in the TZ. I think Alan Wien would argue for that sometimes back in the day. For young folks probably realize he was a big prostate cancer surgeon. They think of him in neurology. And he would say that, but I still think, why do that? And so anyway, these are the reasons. You don't biopsy the apex. That's where all the bad things happen. Both nerves come into play. The sphincter is so close. But you know what? Apical tumors exist. You don't biopsy the anterior part of the prostate because it's hard to get up there. We did it transrectally. So why are we still doing this? Why am I tasked to defend that blind hit? Well, because the MRI is in with that. It's a combination. And the MRI takes the blindfold off that piñata hit person. So this is old information. We know it works. MRI is the future, and it's here. Not just the future, it's here today. And yet, I'm still going to argue that those systematic biopsies on the bottom have some role. But there's the data to support that. We didn't think there was until we looked at our own data. So Dr. Moore left, but groundbreaking work from the folks in London. Historically a great team. Although Hashamed has left, but Caroline and Mark Emerton and the team. And we know that the ultrasound is not the imaging modality to find tumors. This is just kind of background. Minhaj Siddiqui, who is part of this program, wrote up our trial, 1,000 men, same session, MR-directed biopsy plus 12-core biopsy, and this has been confirmed by Precision, other many, many papers throughout the world, that you find more high-grade cancer with MRI, and that the random biopsies find less low-grade cancer, and that's important because we don't want to overtreat. But this is what the data drove us crazy. In this JAMA paper, when we looked at the data, we found that there was 17% of our patients where the MR target missed the cancer. And we knew this early on before we published that paper. And as a result, we were worrisome that MR wasn't perfect. Did the MR miss the cancer? Did the biopsy technique miss the cancer? What was going on? What's happening? Now, yes, it misses far less than the randoms, but it's still not perfect. And, when it's not perfect, it leaves uncertainty and doubt. And if you want to destroy progress, you put doubt in the mind of the physician, and they don't act because they're concerned about this. And so therefore, a lot of overtreatment was well-intended doubt. Why put somebody on active surveillance if they have the aggressive tumor somewhere else? Why put somebody into a focal therapy program if away from your biopsy, away from your focal lesion ablation, there's a high-grade tumor? Let's go ahead and radiate the whole prostate, take out the whole prostate, and buy the harms. That's the doubt and uncertainty. And as a result, the overtreatment that the U.S. Preventive Task Force complained about was real. And we had to figure out a way to relieve the uncertainty for the physician and the patient. And not just the patient, but also the well-intended urologist who did whole gland therapy. So MRI targeting, standard of care. We heard about TP, we heard about TR. It's now under local, high throughput, in the office. On the back days of MRI, there was rumbling that the in-gantry biopsy would be the solution to diagnostic prostate cancer, and that the urologist would give it away to our colleagues in radiology, or unless you own the MR machine. And the urologists need to keep it in their office, and so the MR fusion platforms do that for us. Cognitive is not bad, that's all you have. But then the question for my talk was the 12 cores. So Michael Ledoux, who's now at Cedars-Sinai, looked at a paper where we analyzed the MR targets alone, systematic alone, and what we term the combined biopsy technique with the MR plus targeting. 2,700 patients, 20% of MR were PIRADS 1s. And the first half of this paper that discussed the targeting registration, PIRADS classification, we'll skip. And for time, we'll focus on the 404 patients who went to surgery. I show this just to remind us that we enrich for PIRADS 4s and 5s, as most clinical practice does. But we still do, in this cohort, we wanted to biopsy the PIRADS 3s and 2s to understand what that meant. And in real world, and of course that isn't done, it was done for this study. So again, we'll focus on the 404 patients who went to surgery, and as mentioned in this conference before, we kind of designed this opportunity for a mold to slice the prostate by our pathology colleagues in the exact location as the transverse or axial image of the MRI. And if our MR sequences is every 3 millimeters, we would cut it every 6 millimeters and have really stringent RAD path correlation, which I think in a small way contributed to the adoption of MRI for diagnostic pathways. And we wanted to see the uncertainty, which is the upgrading event. How is it if I did a 12-core biopsy and I want to go into surveillance, I find low-grade cancer, I want to do focal therapy, I want to not treat the entire prostate, how often do we find more aggressive cancer? And if you focus on anything above grade group 2, because that's pattern 4, it's about 30%. And that is consistent with the published literature in many, many series all over the world. And then we thought now we were going to crush it with MRI. So we looked at MRI, and there was an improvement, as you can see, but it's still about 18%. And then that was consistent with the paper from Siddiqui in JAMA. And we realize now that this by itself had uncertainty. And let's say it's 20%. If you had a 1 in 5 chance of having more aggressive cancer with an MR-directed biopsy alone, would you do surveillance? Would you do focal therapy? Now, I get a lot of heat from my colleague and good friend, Mark Emberton, who's an advocate for MRI alone, and says if you can't see it, don't worry about it. Claire Tempany up at Harvard, a wonderful radiologist. And we've been chatting about these things. We're interested in this. And, you know, it's maybe a US, UK issue, but at least in the States, a lot of people still do 12-core biopsies. They're used to it in their office. They have the patient already in position. They have the ultrasound probe. They're doing the TP biopsy. They're doing the targets, except for the additional harm of some more cores, which we can get into in the Q&A. It's not a separate session. You're there. So just go ahead and do those on top of it. And when we analyze the combined data, which is what we see here, which is the ability to take the Gleason grades and tumors from the MR targets and the systematics, we find that that uncertainty, that doubt, that upgrading event to a higher grade, grade group 2 or higher, drops down to 6.7%. So now we feel a little better ourselves that we have a 93.3% chance that we've gotten all the tumor volumes and Gleason grades and counted, and if we go to surgery, we would see no worse cancer. The PROMISE study was close as you could do. They actually did a saturation biopsy template mapped, but here we have that, you know, with the specimens. And this drop from almost a third, 6.7, we felt that would give patients and also their physicians, their urologists, comfort for surveillance of focal therapy, avoiding whole gland therapy. Now, we weren't happy with that. We said, well, is this for all comers? And so we did a post hoc analysis, secondary analysis that we published European Urology Oncology to see would all comers fit this. And because I'm running out of time, and because we want to go home, I'll just cut to the chase by saying when we did our post hoc analysis, and take that with a grain of salt because it wasn't the primary objective, and that's why it wasn't in a certain journal, we said that for grade group 2 or higher, not surprising, if you have PIRADS 1, MR has no benefit. I mean, PIRADS 2, MR has no benefit. Those are often not cancers, so why even bother to use the MR? As you get to 3, it's the same thing. It's only when you get to PIRADS 5 do you see that that really drives the bus. And that biopsy accounted for the highest grade tumor. And if you went for even a more aggressive tumor, say grade group 3 or higher, we see the same thing. So in summary, what we've decided is, at least in our clinical practice, the MRI is so good. The radiologists are so good at reading these MRIs today. And you know, we heard about quality assurance. If it's not the case at your institution, demand better imaging, demand better reads, or seek it out. You know, today everything's digitized. You have wonderful you know, academic centers and companies that you can outsource this to. But if you have good MR quality, then you utilize it. The targeted biopsy, the PIRADS 5, is all you really need. So in summary, I would argue that in the past 10 minutes, I've shown that there is data to support that the continued use of a 12-core systematic, yes, it's blind, biopsy, but it's systematic, it's regional, with the MR-directed targeting, gives you the best chance of detecting all the aggressive cancers that you would need to know before you did surveillance or focal therapy. And if you needed to, for some reason, minimize or strategize an optimal biopsy technique based on PIRAD score, the PIRADS 5 really stands alone for targeting on itself. So the clinical team, many of my nurses are here, many of my support staff is here. You know, you can't bring in, you know, thousands of patients to NIH. For those who've been at the NIH, it's in itself Herculean efforts. Usually it's small studies, small number of patients. This required that. It's because of my team here, listed up here. Some of them are in the audience. I am part of a research team that's been with me for 20 years. And I'll highlight Pete Troike, who spoke today remotely, Barish Turkbey, Marie Marino, who's at this meeting, and then Brad Wood, who came in, as always, and comes in and leaves quickly. And then for the fellows out there, Marshall Linehan loves to quote the FFFs, favorite former fellows. I think Dr. Rassenhat is one of those for sure. I added the F, and I made it FFFF, favorite former focal fellows. Those who are in the society, those who are pushing their field forward, those who are going to advance the field. And many of them are a part of this meeting. Many of them are still with us and will be joining practices and academic settings across the way. So these are the FFFFs. I haven't told Marston this one yet. If I was asked one thing about looking back at my career, what was most important to me, it's these individuals, the medical students who we've trained to go into residency. Some break my heart and go into non-oncological urologic specialties like recon recently. And of course, those who have come through me as fellows, it really means a lot to me. We have a hospital. Some folks don't think we have a hospital. What we do, it's a wonderful place to work. We're actually getting a brand new operating suite. They broke ground. Yes, thank you for those who pay taxes, because you all helped build this. We have new OR suites, all integrated with imaging, CT, MRI, all the suites. Really excited to see this come through. Probably will be ready in about 2 or 3 years. And please come and visit. We're always welcome. Thank you.
So one question while Ruben is coming up. If you get distortion and retraction of the prostate post-focal therapy, how do you adjust for that on your biopsy strategies?
Sure. So more problematic, Carey, if it's hemiablation, for sure. But in our, we've done mostly laser focal ablation, in gantry, out of gantry. And we do focal, so we'll either do quadrant, but we don't do hemi. And then what we'll have to do then is we take the old data, the old MRI pre-ablation, and then we take the new MRI with either retraction or scar. And then, and this is specific to the device, very probably different if it's Artemis or MIM or Amigo or whatever it is. But right now, cognitively, we overlay the two. And at some point, we hope to have software and AI do that automatically with some type of internal fiducial that is consistent across.
Right.
But it's not often you find a cyst like that. But it's a challenge. I agree with you.
Yeah.
Yeah.
A quick question. In patients with prior negative biopsy, when you repeat the biopsy, you can hold the systematic or use systematic plus target?
Good question. And the patients ask that question, Ruben. That is a wonderful question. So just so everybody understands what Oliver said, a patient comes in with a prior negative biopsy, and they say, I already had the pinata 12-course samples. And I'm coming to you because you want the MRI at the NIH. Why do it again? If we find a PIRADS 5, we don't do the 12-core biopsy. We direct it to that area. If we find the PIRADS 4 or 3, and the tumor is in the atypical location, the area that they probably missed, anterior or apical, then we'll focus on that. But if it's not either of those, then we will read the 12-core biopsy. And I will say this. Somebody referenced Misop Han's paper at Hopkins with Dan Stoyanovich. And what they did was they tracked the location of the 12-core biopsies. And even though the cup said left apex, it was left mid. Even though the cup said right base, it was right mid. And we all know that we don't go into the apex. With the new systems that exist today, they force you to be more systematic. And therefore, and our students in the back are going to put this out very soon for an abstract at AUA this year. When we compared the outside 12-core biopsies, and we did our 12-core biopsies using a software system, we find more cancer because we're more systematic. And so therefore, I think if you don't have those systems, I would continue to do that. And I'm excited to see which of those students will present it, but that's what we're looking at. Systematics on the outside, and our systematic 12 cores with our device. Yeah. Oh, John, yeah, Dr. Carey, yes.
Hey, Peter. Just a question about the MR invisible disease. I mean, we define anything with pattern 4 and it as being quote unquote clinically significant. But then you've got sort of the stuff Lori Kloss was showing about the MR invisible disease being less clinically significant than MR visible. You've got some studies where we've got 15-year or more longitudinal follow-up. You know, in the UK, they don't so much use the systematic biopsy, and their outcomes in terms of metastasis-free survival and disease-specific survival are pretty equivalent to
right.
if you are adding it. So what do we need to do to kind of bridge that gap from a research standpoint?
So first of all, Caroline Moore, so Mark Everton was upset with this paper, the NEGM paper, because I did advocate to continue. And in the debate, I didn't mention the Italian paper that did support not using 12 cores, because I thought that would be brought up by Amir or Pin. It was debate style, but that it does exist. Listen, Caroline still does random biopsies, 12-core biopsies. She admitted it to us at dinner a couple of nights ago because she's worried about the invisible lesions. I think the issue is going to be we're hung up on pattern 4 too much. Right? I think if we think of grade group 1 or Gleason 6 as a not cancer, then that minor 4 is in that category. And if it's brackish water, salt and fresh mixing, that's the 7s or the grade group 2s and 3s, then yes, we're hung up. And so that's why, the Siddiqui paper, we wanted to say significant cancer was 4-3. And that's where we start worried about these things. And we do a lot of surveillance for 3-4s, a lot, regardless of percent 4, for the reasons you mentioned. The second part of it, I think, is we're going to have to do better tissue diagnostic platforms, not just the commercial available ones, where you run the 17-gene panel and says, you have a 25% more chance of aggressive cancer than your pattern would say. Well, some folks say that's too high. Some folks say that's low enough. So I think deep down interrogation, we have a whole team looking at epigenetic factors. We have a sponsor. We're looking at samples now, looking at remodeling of chromatin. We're going out to the nucleus. I mean, some of the collaborations that we may have in the future, I think is going to bring in a whole set of information that with AI we'll be able to better scale down high grade, low grade. And so we have that's one thing about NIH. We have so many scientists working on that tissue right now, and we're pulling all this data that we just have to find ways to use it. That's all.
Thank you, Dr. Pinto.
All right.
Good job.
So if you look around the audience, you guys are the diehards, staying to the very last minute. This is exactly the kind of motivated people we need in the Focal Therapy Society working for us. So this is great. We hope you enjoyed it. We hope you found this very educational, a great meeting, made some good friendships, camaraderie. We intended to do that. Wanted to thank Dr. Pinto again for his leadership in bringing in the NCI, the FDA, and all the former fellows, the FFFFs.
FFFS. I'm just glad my name was on top. I'm a little competitive, but I just want to thank everybody. It's been a really labor of love, and everyone that's helped out on the program. And I mean, I've kind of guilted some of my friends to fly in from way too far for a 10-minute talk, but it was good to see them, and I really appreciate you guys making the effort. And every year we'll be doing a North American meeting, but we want to hear about our next meeting in Singapore from Dr. Jack Tay.
Thank you, Art. And thanks everybody for being here at this late hour. And I really want to be very grateful that I have the chance to host you guys in Singapore next year. We're going to do the meeting, FTS meeting, in combination with our Singapore Urological Association meeting. So we're going to make it a really good meeting with a lot of focal therapy content. And we really want to run a very good flagship event. So I'm going to be reaching out to a lot of you to come and give talks and take part. And I really hope that you guys will be there. I look forward to having an opportunity to host you guys. So watch your email inbox. Thank you. Yeah.